Evening, everyone. Thank you all who are able to attend. Again, I'm Michael Knight. I'm an internal medicine and obesity medicine physician and a clinical associate professor of medicine at the George Washington University. However, with regard to this topic at hand, I do serve on the Council of Ethical and Judicial Affairs for the American Medical Association. I'm currently in my second year of a 7-year term. And medical ethics is something that we are heavily, heavily involved in, as you'll learn more as we go through the presentation today. So this was really designed for early career physicians, but it applies across the board. And I know we have some of our leaders on the call tonight, and of course, others who will be watching the recording. And so I'm going to have a very high level. So I'm not going to assume that everyone has the same level of understanding when it comes to medical ethics. But if you have seen this before, then see it as a way to confirm or reinforce the knowledge that you have. And then the new concepts, hopefully you'll see some, we hope that you will be able to apply it to your clinical practice. I'm going to do my best to look out for any comments in the chat, but as those who've done talks before know, sometimes it can be difficult to see all the screens. So if you have a question, feel free to unmute if I don't see you in the chat, but I'll do my best. So when we think about medical ethics, we're really talking about the moral principles by which physicians must conduct themselves. And throughout this presentation, I'm going to be using the term physicians. The Code of Medical Ethics is specific to physicians and not generally speaking of healthcare providers. And so when you see physicians, I'm actually talking about physicians. And as we are a physician organization, this is an opportunity for us as a profession to look inward and say, what are the ethical principles that define us as a profession? But however, not discounting other professions that are also in healthcare. So medical ethics is specifically talking about the moral principles that we as physicians hold ourselves to. We frequently find ourselves facing moral questions and ethical dilemmas in our line of work. It can be a daily situation, particularly those of us who work in acute care settings, ambulatory care settings, public health and population health. These are spaces that almost on a daily basis, we may be required to make ethical decisions. And so medical ethics provides a framework to help us make judgment calls that are morally sound and right for every patient that we are serving. We also acknowledge that something that may have been considered ethical 30 years ago may not be today, and what we think is ethical right now may change in the future. So there are certain core concepts of the pillars of medical ethics that we'll talk about that really don't change, but the way that they are applied as we get further understanding of biomedical advances, our views on them may evolve over time. And so it's very important for all physicians, early career physicians, and future physicians to have a very solid grasp of medical ethics, and that to inform their not only behavior, but their care of patients. So what are the 4 pillars of medical ethics? And I know that we have some folks on the line. I'll call to folks, but I want you to be as interactive as you would like to be. I know it's around dinner time, but when we think about that, the first is beneficence. You all should be familiar with this term. It is the obligation to contribute to someone's welfare, right? So the interventions and provisions should provide benefit directly to the patient, and not just that you're merely avoiding harm. It's that you're doing something that is positively impacting the patient in front of you. The second is non-maleficence, and that is an obligation not to inflict harm on other persons. Harm is to be avoided and minimized. The fourth pillar is autonomy. So respect for persons, and encompasses the right for a patient to be free to make choices about their own body. And one of the things to keep in mind is, particularly in the United States, the pillar of autonomy is often stressed in the medical space. And finally, justice, which is a distribution of health and healthcare in a fair and equitable manner, and requires attention to prioritization and rationing, which happen very frequently in healthcare, but really thinking about, are we benefiting or providing care in an equitable way? And so those four pillars can be applied to almost every decision that we are making in medicine. They are meant to be used in concert and not in isolation. So it's not a situation where I'm saying, okay, if this decision, I will be able to uphold the pillar of beneficence, but I won't be able to uphold the pillar of justice and autonomy, but I'm going to go forward. The idea is all four pillars should be met, and our aim is to uphold all of them. There's no hierarchy in the principles, right? Beneficence is not higher than non-maleficence, is not higher than justice or autonomy. And which principle is most important is going to be dependent on the context of the dilemma. What am I dealing with right now? But these are our guiding principles as physicians. Now, the code of medical ethics, we should all be familiar, but the roots of these codes started all the way back to the Oath of Hippocrates, which we all took as we graduated medical school. And its statements protects the rights of the patient and obliges the physician voluntarily to behave in an altruistic manner towards their patient. So this was an exposition of principles for physician conduct. It was modified in the 10th and 11th century to eliminate reference to deities and used widely in a variety of forms to really mark that entry into the medical profession, and we still do that today. Now, in 1803, Thomas Percival was an English physician and philosopher and published a code of medical ethics that described professional duties and ideal behavior related to hospitals and other charities. The American Medical Association, in its initial meeting back in 1847 in Philadelphia, where it was formed, there were two major items on the agenda, one of which was establishing a code of ethics. This was then adopted at the meeting, and that code drew heavily from Percival's medical ethics that was drafted back in 1803. So the American Medical Association was largely even founded in part, as I mentioned, to establish the world's first national code of medical ethics. And so it is core not only to the work we do, but as an organization of the pillars and the foundation that we stand upon. The code is widely recognized as the most comprehensive ethics guide for physicians, and opinions in the code address issues and challenges that confront the medical profession and represent AMA policy. It is used as a foundation for ethical behavior by most of our state medical boards and organizations, as well as many times the codes of medical ethics at some of our professional societies is oftentimes rooted or founded from the AMA Code of Medical Ethics. So promoting adherence to the professional standards that the code supports is essential, not only to preserving patient trust, but also public confidence in the medical profession. We have to remember that at the time that this was generated, there was a lack of standardization when it came to medical affairs. You had individuals who would represent themselves as physicians, but may have been, if you will, selling snake oil or doing a variety of other things. And so when the AMA was founded, it not only was founded to say, we need a standard, we need to have a level of quality, a level of professional standards that we can ensure if you're going to call yourself a physician, you're committed to this. So the code of ethics serve multiple purposes, right? Number one, it's a public declaration of the values to which members of our profession commit themselves. It codifies the expectations about how we conduct ourselves. It's a mechanism for holding people and their organizations accountable. And it articulates the values that ground the profession of medicine and set out expectations that we should behold in our role as healers, educators, scientists, and leaders in healthcare organizations and institutions without regard to specialty. So once again, the responsibility that comes with being a physician is not ignored. And we know that we have a great opportunity and a great not opportunity, but also motivation to be able to go into people's homes, to go into people's minds and having conversations around allowing them to live their best lives and achieve their best health, which is really an opportunity that many professions do not have. And so coming along with that opportunity is the responsibility and the higher level of ethical behavior that is required of us. The code provides a framework for trust between patients and their physicians, and between the profession as a whole and society. It offers practical guidance in our day-to-day, as I mentioned, for things that will come up in our practice. So it's not just a set of rules. And this is really important because individuals may say, okay, the AMA Code of Medical Ethics, is that the book of laws for physicians? And it's much more than a set of rules to be followed. It is through opinions from our Council on Ethical and Judicial Affairs. It helps physicians think through what's at stake as we engage with patients and work with our colleagues to reach ethically sound decisions. It's a living document, and is often edited as frequently as twice a year. At the AMA's annual meeting and the AMA's interim meeting, the Council on Ethical and Judicial Affairs will present opinions to be approved by the House of Delegates that can then be incorporated in the Code of Medical Ethics. So over time, the broad injunctions of the original code gave way to guidance that was mapped to emergent dilemmas. So the original code, very high level, talked about some of those foundational principles. But then when we started being faced with things like genetics, reproductive medicine, managed care, organ transplantation, health information technology, and others, we had to broaden our perspective when it came to ethical guidance. So guidance evolved with those changes, informed as well by the charge of the 20th century bioethics to recognize patients' rights as the moral agents to make healthcare decisions in keeping with their own personal goals and their own personal values. So today, medicine, and of course the code as a part and the foundation of the medicine that we practice, is called to look beyond clinical care and biomedical science to examine critically what is our relationship with society, and how do we respond to the damage wrought by continuing injustice within and outside of the profession. For the code, that challenge is to codify our ethical responsibility and to join the work of unmaking the structures and policies that have profoundly and adversely affected individuals and communities. And this is a newer perspective. I think those of us who have been involved in organized medicine for some time know that, we've not always been on the right side of history. And so being able to say, actually, as physicians, as healers, it's our responsibility to be at the forefront in calling out injustice and working to ensure that our patients are first and they all have an opportunity to live their best life and achieve their best health. So the Code of Medical Ethics, I hope everyone on this call has been to this website. It is actually a newer iteration. It is a way that we can learn very quickly about ethical guidance. And so the Code of Medical Ethics is separated into two parts. The first part is the principles of medical ethics, and the second are chapters of ethical opinions that are issued by the AMA Council on Ethical and Judicial Affairs. The principles of medical ethics is something that is very foundational, and it's almost like the Bill of Rights, if you will, in the medical profession. So we've long subscribed to a body of ethical statements that are developed primarily for the benefit of the patient. But as a member of this profession, we have to recognize the responsibility to patients first and foremost, as well as to society and to other health professionals, and then to ourselves. And I think this is really important because that's not always been the emphasis when we've talked about medical ethics. We oftentimes would focus on what is our responsibility to the patient. In the last few decades, we started talking about what is our responsibility to society, to other healthcare professionals, and finally, what is our responsibility to ourselves as a physician, as a healer? Because if we don't have a responsibility and retain what we need to be fully functioning physicians, we are not able to put patients first. And that is a newer concept. And you will see that with many of the newest opinions that have come out in the Code of Medical Ethics, there has been a focus on what is the physician's responsibility to take ownership, but also prioritize their own health and their own wellness and their own ability to provide care. The principles of medical ethics are not laws, but they're standards of conduct that define the essentials of what we would call honorable behavior for the physician. So in 1847, that original code that we mentioned retained its form and content and principles through revisions in the early 1900s. But in the mid-1900s, a major change with the intent of distinguishing between medical etiquette and medical ethics appeared in the principles that were adopted by the AMA in 1957. In 1980, there was a revision of the principles that was really in an effort to balance the tension between professional standards and legal requirements. So, for example, one of the principles really said that physicians should not be collaborating with other professions that are not committed to evidence-based, if you will, or scientifically sound practice. And there were legal proceedings against the AMA saying that their rules were restricting collaborations with a chiropractors, for example, and actually had some determinations against the AMA. And so there was work to do to ensure that our principles did not violate any legal requirement. It also introduced gender neutrality, replacing he and his with the physician and the physicians, and continuing to be more inclusive as our profession continued to change and become more inclusive moving forward. In 2001, there was a revision of the principle of medical ethics to add two new principles. One emphasized that a physician, while caring for a patient, regard responsibility to the patient as paramount, and the other asserts that physicians should support access to medical care for all people. And so the principles are really designed not to be changed frequently, but to be high enough level and be able to speak foundationally to our approach to patient care. So let's look through those very quickly. So the first, a physician shall be dedicated to providing competent medical care with compassion and respect for human dignity and rights. This is the first principle of medical ethics and is core to who we are and what we do. The second talks about upholding the standards of professionalism, being honest, striving to report physicians that are deficient in character or competence. So really holding ourselves accountable and not engaging in fraud or deception. The third talks about respecting the law and recognizing a responsibility to seek changes in those requirements that are contrary to the best interests of the patient. The fourth talks about our respect for the rights of patients, colleagues, and other health professionals, and safeguarding patients' confidences and privacy within constraints of the law. The fifth asks us to continue to study, apply, and advance scientific knowledge, maintaining a commitment to medical education, making relevant information available to patients and colleagues, as well as the public, and using our talent and using the talents of other healthcare professionals when indicated. Principle number 6 lets us know that we shall, in the provision of appropriate patient care, except in emergencies, be free to choose who to serve, with whom to associate, and the environment in which to provide medical care. Number 7 lets us know that a physician shall recognize a responsibility to participate in activities contributing to improvement of the community and the betterment of public health. So again, you see how the principles have evolved, not just talking about that patient that's in front of us, but what is our responsibility to the community? And finally, a physician should while caring for a patient, regard responsibility to the patient as paramount. And then, as we mentioned, the last that was added in 2001 was a physician shall support access to medical care for all people. And so these 9 principles are really core and really are something that every physician should know by memory, because it really leads decisions that we are making every day. And it really speaks to our identity as healers and leaders in the medical profession. So the second part of the code is what we call the ethical opinion. So ethical opinions that are issued by CJA, which is the Council on Ethical and Judicial Affairs, that represents the application of the principles to specific issues and areas of professional activity. So we know that medical practice is constantly changing. We're hearing about new things. There's new laws, there's new breakthroughs. Now we have artificial intelligence. Now tomorrow we'll have something else, right? So opinions enable us to revisit some of our ethical positions in light of new professional activities or new technology and procedures, but also track back to those 9 core principles, as well as those 4 pillars of medical ethics. So there are 10 chapters that are broken down currently, all the way from patient-physician relationships, consent, communication and decision-making, privacy, confidentiality, and medical records, going down to genetics, reproductive medicine, caring for patients at the end of life, organ procurement and transplantation, research and innovation, physicians and the health of the community, professional self-regulation, and interprofessional relationships. And we'll talk about a couple of these areas as we go forward. I will, again, revisit and say that these are not laws that are for physicians. They are ethical guidance. And you will see, so for example, caring for patients at the end of life, which has been a controversial topic, particularly within the American Medical Association, for example, thinking of medical aid in dying, or in some spaces indicated as physician-assisted suicide. There's been a lot of controversy between that over the years. And we know that in many states, while that may be legal and physicians may be involved in that, our medical ethics still, our code of medical ethics still has a stance on that. And so just because laws change, or just because there may be a change in how we view things, doesn't mean that the ethical concepts have changed. Sometimes they do, sometimes they don't. And that's what allows us to reflect and look back on those core principles as we make these decisions. So let's look at, as we jump in, 2 of some recent opinions that have come down. So what does the code say about a physician's responsibility to provide equitable care? We've already talked about in our principles of medical ethics, we say that it's our responsibility to advocate for the medical care for all people, right? But what does the code say about our responsibility to provide equitable care or to work to achieve health equity? Anyone want to jump in there? Does anyone know? So we'll go through this together. So this actually was a recent opinion. This was approved by the House of Delegates actually last June. And it was a newer opinion that the council worked on over a couple of years. So the first part talks about the physician's individual practice. And in the individual practice of physicians, it is outlined that we have an ethical responsibility to address barriers to equitable care that arise in our interactions with patients and staff. We should cultivate a self-awareness and strategy for change by taking advantage of training and other resources to recognize and address implicit bias. We should recognize and avoid using language that stigmatizes or demeans patients in face-to-face interactions and entries into the medical record. We should use the social history to capture information about non-medical factors that affect a patient's health status and access to care to inform their relationships with patients and the care they provide. So this language of our individual practice is not just saying this is good to do, right? Or this is something that we should have a goal to achieve. This is saying that we have an ethical responsibility to address these issues. And so when we have conversations around implicit bias and health equity, again, we're not just talking about nice to do. We are talking about our ethical responsibility as physicians. The opinion goes on to say, what not only what should we do in our individual practice, but what you'll find is that particularly with our newer opinions, we are not only talking about what you have to do or you should be doing with the patient in front of you. We understand that physicians are no longer majority self-employed. We are many times a part of larger healthcare organizations. And so we can put out an opinion that says, physicians, it's ethical for you to, for example, not be overburdened with the number of patients you see so that you can still provide ethical care or effective care, right? And so you may say, that's nice, but I work for an organization that says I have to see this number of patients in this amount of time. So the ethical responsibility that we're talking about and aligning with physicians may actually be outside of the physician's control. And that is why now we are starting to see opinions that not only speak to specific physician behavior, but are speaking to health systems and how physicians operate within health systems. And so this goes on to say within their institutions, as professionals with unique knowledge, skill, experience, and status, physicians should collaborate with colleagues to promote change. They should support one another in creating opportunities for critical reflection. They should identify institutional policies and practices that perpetuate or create barriers to equitable care. And they should participate in designing and supporting well-considered strategies for change to ensure equitable care for all. So again, we are now seeing not only is this nice to do, it is our ethical responsibility within our institutions to have an active, not a passive role in achieving equity. And finally, this actually is a newer approach that the council has taken, which is speaking to the institutional responsibility. And so you may say, well, why are we talking about the role or the responsibility of a healthcare institution in the Code of Medical Ethics? Code of Medical Ethics speaks to physicians. It doesn't speak to hospitals. So why is this here? Once again, we cannot expect that physicians are going to be able to do things if their hospitals and healthcare institutions are not aligned, as more and more physicians are becoming employed. And so in this space, it says, as institutions in and through which healthcare occurs, hospitals and other healthcare institutions share medicine's core values and commitment of fidelity, and with its ethical responsibility to promote equitable care for all. Moreover, as entities that occupy positions of power and privilege within their communities, healthcare institutions are uniquely positioned to be agents for change. They should support efforts within the institution to identify and change policies and practices that may perpetuate or create barriers to equitable care. They should engage stakeholders to understand the histories of the communities they serve and recognize local drivers of inequities in health and healthcare. And they should identify opportunities and adopt strategies to leverage their status within the community to minimize conditions of living that contribute to adverse health status. And so once again, this was one of the first times that the council put out an opinion that not only spoke to individual physicians, but spoke to healthcare institutions and healthcare systems. And so something for us to think about, how do we move forward? When we even think about it at the society level, okay? And we talk about the what our members should be doing in DC, what is our role in talking about what hospitals and healthcare institutions should be doing? Again, understanding that many of our physicians would love to do certain things, but they're not going to be able to do it unless their institutions are allowing for it and are being held accountable. So any comments or thoughts on that? Because that's a newer concept and a new approach.
I was unaware that that this code of ethics was developed to the extent that it is, and this is great information for me. Of course, these sound like things that we should be doing, but to have this stated explicitly is really encouraging.
Thank you for that.
Oh, there's my Yeah, I do have not a common question, things like that, because I'm not in an institution and myself, but we create, and this happens in everywhere. We create all these things, which they're wonderful. I mean, it's really nice, even for myself, even though I'm not an institution like a big hospital. I think the hospital is serving to the patients, and it should have a responsibility to help the community that is serving. Um, the question I'm going to put myself in the place of the patient. What is for developing all this? Has any patient been involved in the decision of what they want and what they need? Because with all these questions that we have now, what gender you are, where do you live, how many rooms are in your house, how many bathrooms do you have? I mean, we can go to many details to be sure that we are equitable, the work equitable, so that we understand what they want or what they need or what all those things. Sometimes the patients don't want to do that.
Mm-hmm.
So, and they have the right to do that, or they don't feel comfortable doing it, or they don't want to tell me that they are transgenders. They don't want to say that. So, and I will say it's more people that they are like, why are you asking me all these questions, doctor? Of 10, probably 8 will do that. So I wonder, how much can I go without really making the patient thinking that I am trying to, do something, get in their life.
Yeah. Well,
Um,
mhm.
yeah, no, go ahead.
So I think you made a great point, and it's important to understand that these are guidance and they're not prescriptive. I think, again, you always want to track back to those pillars of medical ethics. And so, to your point, where you say the patient may not want to disclose, that brings us back to autonomy, right? The patient has a right to make certain decisions for themselves. We then all have to say, am I asking these questions? Is that providing a benefit to the patient, right? That beneficence. Am I causing harm by not asking these questions? Or am I causing harm by asking these questions? And that brings in the non-maleficence. And so you always track back to those core things and really have to think about in the moment. And so this really talks about how can we promote equitable care, but it doesn't specify or be prescriptive that you have to survey all of your patients for where they're living or how many rooms in the house, right? Because is that going to change anything? And if you don't have a solution, it actually can be harmful to screen everyone for everything. And then you say, well, thank you. Thanks for sharing your life and your personal information that you may not be excited about with me. And I'll see you in 3 months, right? What was the point? What did you offer? And so this just allows us to say, when we're building systems and we're building ways to support clients, these are some of the things we should keep in mind, but in a comprehensive way, not piecing things out, not just saying, I'm going to ask the questions, but then I don't have any resources or infrastructure to do anything about it.
Yeah, my point here is sometimes we create all these things, but we really are not, which you have brought it up in other meetings too, what is the other person really want?
Right.
Because this is what we think the patient wants, but what does they really would like the medical profession to do for them?
Correct.
I don't know we have that answer, and I don't know if they have really gone to the field and asked that question.
Yeah, I would say that in this space, no. Patients don't currently have an active role in drafting opinion. I will say, however, that when the council comes up with an opinion and puts it before the House and goes to reference committee, we often will hear from patients. We many times will have patients who come to the reference committee and actually provide testimony. This has happened when we were talking about medical aid in dying. This came up when we discussed abortion. This came up in a variety of ways. And so in that way, there are opportunities for patients, but I think to your point, a more comprehensive outreach or a more comprehensive way to identify or listen to the patient voice is very important.
Thank you.
No problem. So let's look at another common point. So what does the code have to say about treating oneself or a member of one's own family? So this is not uncommon. And again, if we have any early career physicians who are watching, this will not be uncommon for you. You get your medical license, you're now practicing, and now auntie calls you because she wants an antibiotic, or your best friend wants an anti-nausea medication. What does the code say about that? So the code says that in general, physicians should not treat themselves or members of their own families. However, it may be acceptable to do so in limited circumstances. For example, in emergency settings or isolated settings where there is no other qualified physician available. And in those situations, physicians should not hesitate to treat themselves or family members until another physician becomes available. The second is for short-term minor problems. It goes on to say, if you do decide to treat yourself or family members, we have a responsibility to document the treatment or care provided and convey relevant information to that patient's primary care physician, to recognize if tensions develop in the professional relationship with a family member, perhaps the result of a negative medical outcome, and such difficulties may be carried over into the family member's personal relationship with the physician, to avoid providing sensitive or intimate care, especially for a minor patient who is uncomfortable being treated by a family member, and recognizing that family members may be reluctant to state their preference for another physician or decline a recommendation for fear of offending the physician. So in this case, again, the code is giving us very specific guidance around a very common issue. And so let's now go over to the actual website. So I'm not sure how many folks have been on or have seen the website. I'm going to try to take this toolbar out. But this is the website, very accessible. And so let's say I want to know, what does the code say about chaperones? I can just type that in like a Google search, and here I have the opinion on the use of chaperones. I may say, okay, I want to know about, what does it have to say about cloning? Here I have information about cloning for reproduction. I may want to know, what does the code have to say about abortion? And that will bring me up to opinions here. So this is really a very user-friendly way to find out, and you will be surprised the number of things that are in here that we just never know. You may not even know. We are here grappling with decisions that there's already guidance around. And so once again, you can go up here. You can see the principles of medical ethics, which you went through. You can see the chapters that help have you the different areas, caring for end of life, research and innovation, interprofessional relationships, professional self-regulation. And within each of those chapters, you can then see the list of opinions that make up. So this one is for physicians and the health of the community, and it speaks to community health, routine universal screening for HIV, impaired drivers and their physicians, disparities in healthcare, routine universal immunization, expedited partner therapy, ethical physician conduct in the media, preventing, identifying, and treating violence and abuse, physician competence, self-assessment, and self-awareness. So all of these are additional topics that are covered, and I encourage all of you to take some time, if you will, and have the time to explore this website. There's so much information here. There is also the Learning Center, where you can get some more information that comes out. Some case examples and are often sent out by our team at the AMA, which is more than just the council. We have a full staff of ethical professionals who support the council and also support our opinions. We have ethics in the news. When it comes to a variety of things, we have ethics at the movies, ethics sidebars. It really talks about other issues that overlie medical ethics. So this, again, is just a very high level overview of some of the core content and the core tenets of medical ethics, but really to encourage all of you, if you haven't already, to take some time, explore our code, because this is for us, right? This is how we as physicians define the work that we do and define the standards of practice that are important for us to uphold. And only through focus and attention on this can we be successful in abiding by and upholding those core principles for our profession. So with that, I'm going to stop sharing the screen, but I think if we may have time for if there are any questions, but I hope that you all were able to leave with something, even if it's just knowing that the code is easily accessible on the website and some of the topics that you may be able to explore. So any comments or questions before we close for the evening?
I think this is a great overview. I learned a lot. I really had no idea. There was so much information readily accessible. And further, I really didn't, like I said, I didn't know about the reach beyond the individual practice into the physician's responsibility for the community. I have felt that that was true, but I didn't know that it was codified in this way. And I'm grateful for your presentation.
No, of course. And for those who attend AMA meetings, I encourage you to attend the Council on Ethical and Judicial Affairs open forum. There's an open forum that's held every meeting, the interim meeting and the annual meeting, that talks about some of these topics. It's an opportunity for physicians to come out and ask questions, give feedback, but also maybe there's a topic that's not covered in the code. Maybe there's something you're dealing with on a daily basis that's a challenge. That open forum is an opportunity for you to bring that to the council, and that may inform future opinions that come out. All right. If there are no other comments or questions, I'm going to turn it back over to Pia. Again, thank you for the invitation to be able to give back to my own society. And it's so great to see so many of our leaders on the call tonight.
Thank you, Dr. Knight. Wonderful.
Thank you. Thank you so much.
Thank you. And thank you, Dr. Knight, for doing this presentation. It really is important. MSDC is a proud part of the American Medical Association, and we rely on these kinds of presentations to help our members, as well as all of our sections. And we are going to be holding more events similar to this in the future. So we encourage everyone to provide their input on what programs would be of interest, and to spread the word. And thank you very much.
Thank you. Have a good night.
Thanks.
Bye-bye.
Bye-bye.